Oxygen is a white cylinder with a tag around the neck indicating oxygen and whether the cylinder is full, in use or empty. The regulator has a Bodox seal which ensures a tight seal, but it can leak as it breaks down due to use and pressure and should be replaced as necessary. The regulator also has 3 prongs which line up with the 3 prongs on the neck of the cylinder. This should be tightened not overly tight at a finger strength using the screw on the side. The oxygen cylinder regulator also has a pressure gauge on the front. This indicates the level of the gas within the cylinder and should, at 2000 psi, indicates it is a full tank. As this is a high pressure cylinder and flammable gas, safety considerations include that it should be kept lying down when not in use, as falling could damage the regulator. It should also be used in a well ventilated area and away from flame. You should also avoid contact with oil, grease and lubricants. Indications for oxygen use or oxygen therapy are for patients with a SPO saturation less than 94%, airway obstruction, respiratory distress, shock, an inability to obey commands due to a traumatic brain injury, carbon monoxide poisoning, smoke inhalation or decompression illness. Caution should be taken with patients who are morbidly obese, are on home oxygen delivery or with cord, as these patients should usually be kept at a saturation between 88 and 92%. There are several delivery devices available, and depending on the volume required or whether they need nebulized medication. Rule of thumb is always to use the simplest device at the lowest appropriate flow rate. For the purpose of this demonstration, I'll be using the nasal prongs. These should be used at a flow rate between 1 and 4 litres per minute. Attach the tubing to the nipple on the side of the regulator. Turn on the oxygen using the tap on the top and set your flow rate prior to placing the prongs on your patient. This is done by wrapping the tubing behind the ears and placing the prongs in the nostrils. You can tighten using the slidey piece underneath. This is the LSU suction unit, which is found on pretty much all ambulances. When you take it off the wall, away from its charge source, to do its test, you need to complete the check of all the tubing to make sure there's no punctures, that the unit is all put together and tight, and you'll need to run a test for this unit itself. To do that, you'll press and hold the test button at the top and turn the unit onto full. Then occlude the tubing and it will slowly go through each of its different pressure. The unit checks all the pressures and then the test is complete. Indications for using this unit is for the physical removal of secretions to maintain a patient's airway, such as when fluid is interfering with the ability for them to maintain their own ventilation. And we're generally talking about vomit, not necessarily just small amounts of blood or saliva. When using the unit, the suction catheter, there is a hole on the end which needs to be covered in order for the unit to suck through the catheter. Rules are that you'll only suction as far as you can see. Rigid catheters, such as this one, are not to be used in moving vehicles, and you'll only suction as you're gently withdrawing the catheter, not rolling it around. Maximum amount of time is for 8 to 10 seconds of suctioning. You'll also need to be sure to keep the unit upright, as it may clog with debris if it tips over. On the side of the unit is usually found a little bottle of liquid. If you suck some of this liquid up first prior to starting, that'll lubricate the pipes and help prevent any blockages. The OPA, oropharyngeal airway, is indicated for patients who require airway support. It cannot be used in patients who are conscious, semi-conscious, or who have a gag reflex, as this may cause vomiting. The sizing of the OPA is from the mouth to the mandible. For insertion, we do a chin head tilt. The OPA is then inserted upside down, rotated 180 degrees until it comes to rest on the natural curvature of the tongue. Benefits of an OPA: prevent obstruction by the teeth and lips, and it can act as a bite block. It could also be suctioned through if necessary. However, it does not prevent or isolate the trachea or prevent aspiration. The NPA, nasopharyngeal airway, is indicated in patients with gag reflex, patients with trismus, or patients who have damage to their oral cavity. Caution should be taken as it can cause bleeding on insertion. It can kink because of its soft rubber nature, and it may pass into the cranial vault if there is a skull fracture. Sizing of the NPA is from the nostril to the earlobe. Insertion, we must be sure to lube it well, and we will then select the largest nostril for insertion. So we will gently start to insert, and then if we are met with resistance, gently rotate and then continue. We will never force it. The NPA can also be suctioned through if necessary. The unit, press the green button. We can set it to manual mode. Check the batteries on the back, and we can do that by pressing the little toggles. It'll show us what each battery level is. Number 1's showing low, so we can remove the battery by the little pop on the side, take the battery out, taking a new one, and reversing the process and put it back in. The unit's also showing us that number 1 battery is low on the screen here. Check the paper in the machine by opening the drawer here and then closing it back snugly. We can ask it to do a system test by using the options button, the toggle here to select user test, and then the little centre to ask it to do its thing. Can take a few minutes. If the test is complete, it'll say here that it's passed and print out a piece at the bottom. You can take the blood pressure by attaching the cuff to the arm as normal and then pressing the NIBP button here, non-invasive blood pressure, and it will show you on the unit. You can change the volume by again using the options and then the toggle button, selecting it, and then changing the volume amount. You can change the information that's displayed on the screen by pressing the lead, and you can select whether you want it, the leads 1, 2 and 3, which what you'll attach on the patient. Or you can ask it to show the SpO2, the paddles, etc. So our patient's currently dead, he's got no thing. You can ask it to change the size as well by pressing the size button. It'll show you here. You can change the different sizes. To run a test defibrillation, you can lower the energy select by the buttons on the top. We'll lower it down to 50. However, I don't have a charge pack, so we're just going to disarm, but I'll point out how to do it. Ask it to charge. It'll charge when it's ready to shock with the test load. This is an actual charge. You can press shock. To dump the load, we use the toggle button. It's important to note that this is dealing with live energy. To turn it off, press the on button and it shuts the system down. Vital signs are an indication of a patient's physical condition. They're monitored over time to note significant changes. This demonstration I'll be doing heart rate, respiration rate, blood pressure and oscillating the chest. There are many sites on the body of where you can take a heart rate, and the normal average adult range is between 50 and 90 beats per minute. Batman, do you mind if I take your pulse rate? I'll be doing that from your wrist.
No, go ahead.
Okay. So when we take the radial pulse, it's important to use fingers and not thumb. And we're feeling for the strength. So I'm looking, Batman here has a nice normal, strong and regular beat. So I will monitor this for 15 seconds and then I'll multiply it by 4. So I counted 17 beats, multiplied by 4, gives me a heart rate of 68 beats per minute. If Batman had an irregular rhythm or it was weak, I would have monitored it for the full minute and then noted it. If using an ECG, it's important also to palpate the heart rate, because an ECG will monitor the electrical activity, whereas the palpation will show me the mechanical output of the heart. Now's the ideal time to discreetly count Batman's respirations. We avoid telling the patient, as breathing can be voluntary, and if a patient knows, they may vary their rate that they are breathing. While looking at Batman's breathing, I'm looking for the depth of her breathing along with the effort required for each breath. The normal average adult will breathe at a rate of 12 to 20 breaths per minute. I'm going to monitor Batman and count the respirations over a period of 30 seconds. Over the period of 30 seconds, Batman had 7 complete respirations. So I multiply that by 2. That gives us 14 breaths per minute. Had I noted any irregularity or any struggle with her breathing, I would have monitored over the full minute. Their blood pressure measures the pressure applied to blood vessel walls as the heart beats. The diastolic reading is when the heart is at rest, and systolic is as the heart contracts. The normal adult range for a diastolic is 60 to 80 millimetres of mercury. The normal systolic range is 90 to 140 systolic millimetres of mercury. Batman, is it okay for me to take your blood pressure just by placing the cuff around your arm there? Yep. The cuff goes around the upper portion of the arm. I've already asked my patient to remove any unnecessary clothing, so that gives us a nice snug fit. I'm then going to feel for Batman's brachial pulse, which will identify where I'm going to place my stethoscope valve later on. I'll palpate her blood pressure. I'll ask the patient to hold my pressure gauge, and then I'm going to palpate her blood pressure. I'll do this by inflating the cuff until I can no longer feel her pulse in the radial artery. And then I will slowly deflate until it comes back in again. So I felt Batman's pulse come back in at 120. That gives her a systolic of 120. Testing my stethoscope's turned on the right way. A little tap to the bell and I can hear it in my ears. Again, I'm feeling for that brachial pulse, and that's where I'm going to place the bell of my stethoscope. I'll inflate the cuff until I can no longer hear her pulse, and then slowly deflate until it comes back in again. So Batman's blood pressure, 120 over 80, which is within the normal adult range. Palpation of the chest. I'm listening for abnormal noises, such as whistles, weasels, crackles, a stridor. Do you mind if I listen to your chest there, Batman? Oh, go ahead. So we're placing the stethoscope, the bell of the stethoscope, just on the top. And Batman's going to take a nice breath in. The other side. Normally we would listen to skin contact, not through clothing, but we're not going to take Batman's clothes off for this video. Nice breath in. And we would repeat on the back as well. It's important to note that we're listening for those unusual sounds. Quiet is okay, and absence of sound is not. We'll do a reassessment of vital signs, because one set will set your baselines, and then multiple sets will show you a trend over time. For status 1 and 2 patients, we would repeat this every 10 minutes. Status 3 and 4 patients, we repeat every 30 minutes. Many types of open wounds: abrasions, amputation, avulsion, incision, laceration, penetrating, and puncture. For easily controlled bleeding, examine the wound for any foreign matter, clean it using saline or tap water, and then close it using an appropriate sized dressing which has been dampened with saline to prevent sticking. After the dressing has been applied, reassess the limb. If bleeding controls, apply additional pressure and elevate the limb. You can apply additional dressings, and then you'll need to reassess the limb afterwards. Additional pressure can also be applied by a nifty little twist in the bandage as necessary. When applying the dressing, wrap from below the injury up. This will help shunt blood away from the wound and help prevent venous congestion and further bleeding. For uncontrolled bleeding, a combat application tourniquet can be used. These are placed above the site of injury, at least 5 centimetres proximal. Pull the self-adhering band very tight and then rotate the windlass until you can no longer feel a distal pulse. This is locked into place, and then be sure to write the time that the tourniquet was applied. Reassess the injury site, checking for bleeding. If there is blood all over the tourniquet and you can't write here, you can also use the patient's limb or on their chest or any other part of their body that's appropriate. On the tourniquet, the part of the buckle, there is a second loop if it is going around a larger limb such as a leg. Indications that a patient may require a collar are due to a mechanism of injury that could injure the cervical spine. And the patient may have a tenderness at the posterior midline or focal neurological deficit, a decreased level of alertness. There may be evidence of intoxication, or the patient may clinically have apparent pain or other factors that may distract the patient from pain of cervical spine injury. Application of the collar, we'll be telling the patient, Carrie, you need to remain quite still and not move your head. I'm going to be fitting a collar to support you, okay? Good. We'll have removed any headdress, such as helmets. I'll have done that with assistance of my colleague. They'll be in the supine position with support to their head and neck from my colleague. If the head was at an angle, it is okay to gently bring that head back into a more neutral alignment, but not by force. Sizing of the collar, we use our fingers and measure the neck. Carrie has three fingers, so we'll do that with our collar as well. And it is simple to move the collar up and down, and then locking it into place with the tags on the side. We can gently slide the collar behind the neck of the patient. We fit the chin under the patient's chin, secure it tightly with self-adhesive piece, and keeping it supported, his head supported with a towel at the back of the head. It's important that no spinal injury management is better than poor spinal management of the injury. We can recognise a fracture by pain and tenderness in the limb, deformity when we compare the two limbs, swelling, a decreased ability to move the limb, and the patient may have heard or felt a snap, may also hear crepitus. If in doubt, treat the patient as if a fracture is present. We'll reassure the patient, so Carrie, I know you've hurt your arm. What we're going to do is we'll need to just expose and examine the limb. We'll do that also by comparing both arms. We can also offer you some pain relief, some medicines, but the splinting will also relieve some of that pain. Okay? Yep. So we can offer you some methoxyflurane. Methoxy is an inhaled pain relief. Okay, we can also use that in addition to paracetamol, ibuprofen and tramadol, which has an onset of about 30 minutes. I can see you're able to obey commands as it is a self-administered medication. So just checking your family history, your personal history, that there's not no malignant hypothermia, no known renal impairment, and you haven't had it within the last week. No. Okay. So the onset, it takes about 1 to 2 minutes for you to feel the effects, and it lasts for about 2 to 5 minutes. And adults can have up to 6 mils in 24 hours. Adverse effects that you may experience include some sedation, lightheadedness, nausea. You may also dislike the taste or smell. Okay. So we take the little bottle, tip it into the back of the whistle here, put them together, and it goes through the charcoal filter. It's important that you exhale through that whistle. There are also cautions for use amongst patients who are older than 75 years and those with preeclampsia, as this could worsen renal impairment. With the limb, we need to check the baselines, so our patient is nice and comfortable on pain relief now. We'll check the baselines, so colour, sensation, warmth, movement of maybe his fingers. We'll check distal pulses and his capillary refill, just to make sure that there's good circulation through that limb. Preparation of our splint. Preparation of our splint. We have a nice little bit of padding in here, and Kerry's going to continue to inhale on his methoxyflurane as we go. I'm going to maybe suggest he takes a couple of deep breaths, and lots of them. We're just going to gently put the splint so that it supports the joint above and below the site of injury. When we secure the splint in place, we'll also be very careful to wrap only the areas above and below, not over the injury site itself. Once this is in place, we will then again check the baselines. So again, we'll be looking at the colour, the sensation, warmth, movement of his fingers if he can, those distal pulses, and his capillary refill. Changes around the patient. Hello, hello, can you hear me? Can you hear me? Non-responsive. Checking airway. Nothing in the mouth. Checking breathing. Head tilt, chin lift. Feeling the cheek. Feeling my hand. Looking for rise and fall. 10 seconds. No cardiac pulse. Please start compressions. AUT1 calls control. Go ahead. Patient R49 confirmed, requesting R50.
Confirmed.
Confirmed. I'm going to attach the AED while you do compressions. Please continue until I give you further instruction.
Okay.
So our equipment is strategically placed where everything is easily accessible by both of us. One on the up here. One bar.
Analyzing heart rhythm. Do not touch the patient.
Do not touch the patient.
Shock advised. Charging.
Everyone stand clear.
Stay clear of patient.
I'm looking down the body at everyone. Stand clear.
Deliver shock.
Stand clear.
Now. Press the
Shocking.
orange butt shock delivered. Pause.
Please continue
Start
compressions.
CPR.
Putting OPA. Compressions 1 moment while I give 2 breaths. I'm looking for equal rise and fall of the chest. Continue compressions. When you get to 25, Please start counting out loud. At 30 I will administer 2 breaths. So Kerry is doing compressions at a rate of 100 beats per minute and a depth of 1/3 of the patient's chest. He's also allowing for a full recoil.
25, 26, 27, 28, 29.
2 breaths.
Chest rise.
Chest rise and fall and equal. We'll continue like this for 2 minutes, and the EED will prompt us when it does its next test, when is a good time to change.
25.
So I'm using my hand to support the mask tightly around the patient's airway, mouth and nose, and I'm using my fingers to keep the chin lifted and the airway open.
25, 26, 27, 28, 29, 30.
2 breaths.
Chest rise.
Chest equal, rise and fall.
Stop
So
CPR.
we can
Stopping
exchange.
CPR.
Analyzing heart rhythm. Stay clear of patient. Analyzing heart rhythm. No shock advised. Pause.
Continue.
Continuing with
If
compressions.
needed, start CPR.
22, 23, 24, 25, 26, 27, 28, 29, 30. 2 breaths.
Chest rise. Chest rise.
Staying alive. 7, 28, 29,